Okay, let's give another welcome to Dr. Weinstein.
Thanks. First, I would have never agreed to this if I had known Tomvi was going first. There's no way I would have followed her. And I ahead of time apologize for some of the animation. I got a little bit crazy. Haven't done a PowerPoint in a little while. So my talk is really about what I think every IBD patient should know about their own disease, and in that way be their own advocate. These are the questions that really I need to know when I meet somebody for the first time, and I really think therefore everybody who has IBD should just come in. They should know this off the top of their head. They should have either a cheat sheet or something. But these are the most critical things. It's not a huge paper. They come in and they say, did you get the records from my doctor? Well, I can do that, but these are things they should know too. And these are the most important things. So the first thing is, when did and this is for Crohn's disease initially, and then they'll really be mimicked by UC, but when did my symptoms start? Oftentimes people are diagnosed after their symptoms start. Their symptoms may have been 2 years before they were diagnosed. And then what were the symptoms? People I meet as an adult GI physician treating IBD is sometimes they can't even remember quite what they were. But they're important because they'll often be repeated when they flare. And when was my diagnosis made? I find all the time that people can't quite recall. And then again, with Crohn's disease, where is my disease located? Many people don't even know that. This is just a breakdown of where Crohn's generally breaks down. So 50% will be both in the small bowel and the colon, and then 30% small bowel, and then 20% just simply colonic. And then another 5% maybe will be proximal disease. They'll have it in their stomachs or their small bowel in the proximal portion, and all that's very important. And this is very simple, in my opinion, very simple information, but critical. Again, to me, where is it located? It makes a difference in all kinds of management. And then for UC, really, it's the same thing. Where is, when did the symptoms start? What were the symptoms? When was my diagnosis made? And where is my disease located? And you see, it might just be in the rectum, and that makes a big difference, or the rectus sigmoid, in terms of what medical management you're going to use, and when you're going to start colon cancer screening, and et cetera. And so those are the three primary. We call it either proctitis or proctosigmoiditis, and I would really break those almost up into two things, and then left-sided colitis or just pancolitis. So therapy, this is also a very important thing. What medications have you been on is what I'll ask, and when were they started? These are, again, easy things I think a person can do, and if it's a child, then the mother or the father can keep these records. And if they were started and stopped, when and why were they stopped? And we'll come back to that on another slide. And what dose were you on? That's also critical. And we'll come back to that on another slide. And then also, was the drug effective, or did you just stop it because people say it just didn't work? Well, and we'll come back to that answer on another one. And when you're started on particularly an immunomodulator or a biologic, which is really more often the case these days, it's really standard of care to look in 6 months, and in some cases with some a little earlier and some a little bit later, because they, like vedolizumab, may have a little bit of a slower ramp up. But approximately 6 to 8 months, you're going to want to look and see if the drug you're on is doing what everybody we both think it's doing and should be doing. And we can also do this, and I often try and correlate my colonoscopy with the stool calprotectin or lab markers. So this is what it looked like, and this was the calprotectin. Some people will have a high, elevated calprotectin at 200, but their colon maybe look really pretty good. And so I can somewhat gauge that. If they're 200, even though it's elevated, I can follow that over time. It gives me a kind of a metric or a barometer. And again, was the drug effective, or did it demonstrate efficacy when you repeated the colonoscopy? And this is really important, and this is why we repeat colonoscopies either after the institution of them and for surveillance of disease activity, is because how you feel very, very often does not correlate to what's going on. And that's just a discrepancy that's unfortunate. I wish it was always one-to-one, but it's not. So this is kind of an addendum to the last slide that I kept referring to. So if a medication is stopped, why was the medication stopped? Most patients that I see always say, well, the doctor stopped it, or it just didn't work. Sometimes they'll say, I had an adverse effect, but I can't remember what it was. But the important thing, if it's not an adverse event or effect, and they just say, well, it just didn't work, how do you know it didn't work? Medications need to be optimized. And if I put you on Remicade at 5 milligrams and you're not doing well, and you're on it every 8 weeks, and we both say, okay, the medication doesn't work, well, we really haven't given it a chance. We haven't checked your levels. We haven't optimized the medication. There's a study years ago called the Taxit study that showed about a third of patients, when they started a medication, aren't going to be at the right levels. They'll be maybe too high or too low, but you need to optimize them. And that's important. If you're on a drug and your levels are perfect, everything's optimized, and you're still having symptoms, then perhaps you might be a non-responder. But again, so was there any attempt to adjust the medications, move Humira to every week, and increase the dose of Remicade, or increase the regimen to every 6 or even 4 weeks? Again, levels. Did the Remicade simply fall out of favor because you were getting a drug that had no levels to it? And you check that, and there are antibodies. But if there are antibodies, it's also important to know, well, I did get antibodies, but did you try and reverse them? They're really, actually, if you develop antibodies on Remicade, we have a really high success rate of reversing that pattern if we institute an immunomodulator like methotrexate or azathioprine or 6-mercaptopurine. But this is all trying to preserve a medication, because the first medication you're on in IBD is the most critical. It's the most important drug. And you always want to try and preserve it by all means. And then the reaction, was it a true adverse reaction, or was it not? And that sometimes can be very hard to determine, and sometimes it's immaterial because patients not unreasonably will say, I'm just not going to take the drug. I had this happen, and I'm just too afraid of it. And again, so drug effective, did it lose its efficacy? And this is also important. I think that before you stop a medication, especially one that had some efficacy to begin with, that you look, because there could be a concomitant infection. You could have C. diff. You don't have to necessarily look for C. diff. But if you're on a biologic, with or without an immunomodulator, you can develop viral illnesses that can be concurrent. And the symptoms, alternatively, your colon may look great, and your symptoms may be more due to functional disease and have nothing to do with inflammatory bowel disease. One of the reasons that we've gotten away in our studies from looking at the Crohn's CDIS, the Crohn's Disease Activity Index, is because it's really not a good metric. Somebody with IBS or functional disease can have a score. If you ask them if they're on diarrhea, having diarrhea or symptoms, they may have a score that's higher than somebody with active IBD, because all the symptoms are very similar, and there's a real big overlap between the two. So I think it's very important to relook before a drug is abandoned. I guess the bottom line there is do everything you can to make sure that that drug that you're on is optimized and preserved, and know the reasons why. Infections. So this is also an important thing to know. And again, I think all these things are very easily put on a sheet of paper by yourself or your parent, if you're the parent of a child. But when was the last endoscopy? When was the last colonoscopy? And why were you doing it to begin with? Was it a routine, you felt great, or were you in a flare at the time? What did it show? And what medication were you on during that time? All these things are helpful to the practitioner historically. And Tomby actually just covered this, and had I known it, I probably would have made it shorter. But basically, there are certain standard of care for preventive care for patients with IBD that we think is very important. I think foremost among them are standard immunizations, the pneumonia shots, Pneumovax, Prevnar, obviously COVID. Shingrix is not actually on the standard of care. I think it will be in the coming years. There's no reason why it shouldn't be. I think the only reason why it hasn't in the past is because you couldn't get covered, essentially. But now, last summer, the FDA has approved Shingrix and recommended it for people who are quote-unquote immunosuppressed or on biologic medication. And so if you're on it, you should, I think, have the Shingrix vaccine. I like, and this is my own practice, a DEXA scan is something that I'll get as a baseline, even if you're 25, if you've had your disease for a time period, whether or not you've had steroids, and Tom V alluded to this, the disease itself is osteopathic for a variety of reasons, and that Tom V pointed out, malnutrition, steroids, and inflammation itself. And dermatology checks if you're on certain medications, biologics and immunomodulators among them. I like my patients to have it at least a year, annual checks. And that also, I didn't put it up there, but Tommy mentioned people on 6-MP, women on 6-MP rather, are at increased risk for cervical cancer. And so I do advocate if they're young that they get the Gardasil immunization, and that they're always getting their pap smears annually at least. And then I personally am a big advocate of at least getting biannual labs. I think that is very important. These medications are extremely safe, in my opinion, but nevertheless, things can creep up that you don't know about. You won't feel elevated liver tests, for example. So radiology, this kind of, again, when was what imaging have you had? Was it a CT or an MRI? We prefer an MRI because it gives you less radiation. And somebody who's diagnosed at 20 or even earlier, they have a long life ahead of them. I'm not actually that concerned about whether it's a CT or MRI, and somebody who's elderly, that radiation to me is unimportant. It's negligible, but at the same time, an MRI I think is a better exam. Was it an M2 capsule? And again, what did they show? And so you should be able to tell that to your doctor. And then concluding, these are just basic things. This is applicable honestly to even your primary care. But what are the best parts of a patient-doctor relationship? How do you get the most out of it? Well, first, you got to feel comfortable with the doctor, and the doctor has to feel comfortable with you. You have to have some trust and open dialogue. If something arises and there's a disagreement, I would urge you not to just abandon the doctor, but talk about what the problem was. It's a relationship, it's a marriage, so talk about it. You don't have to go into therapy with somebody, but that probably is going too far. But, troubleshoot. I can't get in touch with you. We'll figure out a way to make sure that doesn't happen. And again, patients, doctors, and you can have two people. I can meet somebody. We can both be wonderful, beautiful people, but it's like dating. Just wasn't a match. And then you could even use your provider to help find that. Well, maybe I think you might be better off with so and so. And then I think it's also important to talk about what the goal is of your therapy with your doctor. Ideally, it should be a treat to target, and the target we talk about is ideally complete remission. When we look, not just that the colon or the small bowel looks good, but you can't even find any evidence of disease. Now, obviously, that's not a target that we're going to achieve all the time. So there are times where you agree that we're not at our goal target, but we're at a good target, and to do anything else would probably be folly. And then compliance is another big, an important part of the doctor-patient relationship. I think that for me, I like to see my Crohn's patient or IBD patients at least twice a year. I almost insist on it, and if I could keep them all in my head, I would. And when I get their infusion records, the first thing I do are their medication requests. If they haven't been there in 6 months, then I tell them, they're either not going to get the medication or they need to follow up. And even when you're feeling well. So that is it for me. Thank you, Tanvi. Just wanted to thank her for everything. She's wonderful, and again, I would have never done this had I known that. So I figured I'd throw a picture up there. Thank you.